Hey everyone. I too would like to begin by thanking all of you for joining today's webinar. Our presenters will provide information on respiratory viruses of concern in healthcare facilities, preventing institutional outbreaks and measures, the role of the environment and the spread of respiratory viruses, and environmental technologies to enhance mitigation strategies, while sharing their experiences using Synexis dry hydrogen peroxide, or as we refer to it, DHP, and how it can play an integral role in your environmental bundle. It's my honor to introduce our two presenters today, starting with Michelle Vignari, who has 27 years of practical clinical experience, clinical leadership, and is board certified in infection prevention and epidemiology. She is the Director of Infection Prevention at the University of Rochester Highland Hospital in Rochester, New York. She also serves as an independent infection prevention consultant. Currently working in an acute care hospital setting, Michelle also comes with vast experience in the ambulatory and long-term care health arenas. In 2011, Michelle was one of 12 professionals chosen nationally by the Association for Professionals in Infection Control and Epidemiology as a hero in infection prevention, and in 2017 was awarded the Mark to Dimes Nurse of the Year Award in the area of infection prevention. She's an active member of APIC and is currently the past president for her local chapter, the Rochester Finger Lakes chapter. In addition, Michelle is president of the New York APIC Coordinating Council and also serves on the New York Department of Health Technical Advisory Committee, a council of subject matter experts who work with the New York State Department of Health. She has published extensively in peer-reviewed journals, and she contributes to the infection prevention and scientific community as an ongoing way. Again, moving to our second presenter, Mary Colt. Mary has more than 30 years of nursing experience in critical and long-term care. Currently, Mary serves as the infection control specialist and project manager at the Highlands at Brighton. It's a 145-bed skilled nursing facility in Brighton, New York, along with being an adjunct clinical instructor for the Wegmans School of Nursing at St. John Fisher University. Mary provides ongoing service to the Association for Professionals in Infection Control and has also been involved with various ad hoc projects with the CDC, the Emerging Infections Program, and the Certification Board of Infection Control. Mary is actively involved in bringing research initiatives along with the adoption of technology into the long-term care arena and has recently published a peer-reviewed study on the impact of dry hydrogen peroxide in long-term care. We hope our webinar attendees find today's information valuable and actionable. And now I'd like to hand it over to our presenter to get started. Michelle?
Thanks, Denise. We'll start off today with our objectives. And Denise kind of touched base on them a little bit. We're going to talk about respiratory viruses of concern in healthcare facilities, how to prevent institutional outbreaks with prevention measures, the role of the environment in the spread of respiratory viruses, and different environmental technologies to enhance mitigation strategies. Next slide. So what's in store for the upcoming respiratory season? So as many of you may remember, in the beginning of COVID, we actually saw many of these respiratory viruses disappear for the first couple years. When COVID was circulating heavily, we did not see RSV and flu historically seasonally like we had in the past. And that was because of the strict public health measures that we had in place. And then since then, they have loosened up a little bit. We have now the concern of a triple demic of when we do see RSV, flu, and COVID circulate sometimes at the same time. Next slide. So let's start with flu overview. So flu is a contagious respiratory illness. It usually infects the nose, throat, and at times the lungs. Flu A and B are the two viruses most responsible for seasonal flu epidemics, more commonly known as flu season. Although influenza A viruses are the only influenza viruses known to cause pandemics. And in the below infographic, you can see the different types of flu. They have subtypes and lineages, and then they can be broken down into different clades and subclades. When you're talking about our seasonal flu that we usually see, flu A, we have H1N1 H1N1 and also H3N2. H1N1 typically affects the younger population, and very often, unless you're in a pediatric institution, we don't see in acute care as many hospitalizations in H1N1 years as we do with H3N2. Seems to affect the older population over 65, 70. And those are the years that we really tend to see an increase in adult acute care hospitalizations. Next slide. So transmission of flu is spread by means of tiny droplets. So basically, when somebody coughs, sneezes, or talks, think of the 3 to 6 foot rule. You know, you cough, you sneeze, those droplets go 3 to 6 feet, and then they drop to the ground. Sometimes also you could have indirect transmission. So a person might get flu by touching a surface or an object that has flu virus on it, and then touching their own mucous membranes. Think of those high touch surface areas, doorknobs and things like that, that could be a source of indirect viral load. About 8% of the population every year gets the flu. The onset of symptoms are usually 1 to 4 days, with 2 days as the average. One thing that is really unique about flu is it's usually an abrupt onset. So you will hear people explain they were perfectly fine, and then all of a sudden, boom, they got hit and they felt like they were hit by a bus. It's usually an abrupt onset. Your period of contagiousness is usually the day before symptom onset and up to 7 days after being sick, although individuals that are immunocompromised may shed longer than that 7 days, and you're most contagious within that 3 to 4 day range. There are complications of flu, which can include pneumonia, ear infections, sinus infections. Those that have chronic medical conditions can see an exacerbation of those, such as CHF, asthma, or diabetes. And then also one of the things that is true with all viruses that I'm not sure a lot of people really understand is that viruses can cause an autoimmune trigger where your body can go into overdrive and, affect other organs in the body. I will give you an example. My son is a type 1 diabetic. And, when he was first diagnosed in 7th grade, the first thing I thought of was, his great grandfather had diabetes. It must be hereditary. And even though I had been a nurse for 20 plus years, what I didn't realize, one of the first questions they asked me when he was admitted into the intensive care unit was, has he been sick lately? And he actually had flu A 2 weeks before he was diagnosed. And very often these viruses can trigger an autoimmune response where it attacks different organs. And in my son's case, it attacked his pancreas, and he's now a type 1 diabetic. In the hospital, in acute care settings, and actually even Mary will touch base for long-term care, we do institute transmission-based isolation. For flu, it is droplet isolation, since that's the main mode of transmission. And we isolate these people for a minimum of 7 days after their onset of symptoms. At day 7, we evaluate them for improvement of signs and symptoms, afebrile for 24 hours. And at that point, we can remove them from isolation. Next slide. So disease burden. The CDC estimates between 2010 and 20, influenza resulted up to 41 million illnesses. There were between 710 up to 710,000 hospitalizations and up to 52,000 deaths annually. So I think if you're not in healthcare, a lot of people don't really realize the morbidity and the mortality that seasonal flu can have for an individual. Next slide. So flu season. So in the US, flu season usually occurs in the fall and winter. Although it does spread year round, most of the time flu activity peaks between December and February. The overall impact varies from season to season. And so, I'd say flu is predictably unpredictable. If you look at the graph on the left, this shows an institution. The blue line is flu A, and you can see it started to rise in January with a peak really as late as April, and it kind of still circulated through May. And then if you look at the graph of last year's flu season for an institution, you can see they started seeing flu early in October, it peaking in November and December, and by January, flu was literally gone and not circulating anymore. So every year is a very different year when we try to predict flu circulation. Next slide. So flu season forecasting. So flu in the Northern Hemisphere is often caused by viruses very similar to what they see spreading in the Southern Hemisphere during their winter flu season. This year in the Southern Hemisphere, flu season had an earlier peak than its typical peaks. And most of the flu circulating, about 90% was flu A, H1N1, and only 10% was flu B. Like I said, H1N1 often affects the younger population. That is especially what they saw in Australia. And they also did see that the flu vaccines had really significant protection. It protected from flu A hospitalizations up to decreased hospitalizations of flu A by 55% and against flu B by 46%. Next slide. So we're going to jump to COVID. And as you can see, this is a very busy slide that I'll try to go through quickly. COVID is much more complex than flu and RSV that we're going to be talking about. As many of you know, COVID is caused by a virus called SARS-CoV-2. It is very contagious and it can spread very quickly. It most often causes respiratory symptoms that can feel very much like the cold, the flu, or pneumonia, and it can also attack more than your lungs and your respiratory symptoms. With the large array of symptoms, it makes quick diagnosis sometimes very challenging. So what I mentioned about the flu is people usually feel like they got hit by a truck and they're sick. With COVID, there are so many different symptoms. There are mild sinus and respiratory, GI, and a lot of people will have things just kind of lingering for a day or two, thinking it's just their sinuses or just allergies, and then all of a sudden get a progression of symptoms. And that's what makes transmissibility so much more challenging, because many people are walking around with very vague symptoms, but yet they're shedding live virus. When it comes to transmission, this has been an area of debate over the years of the primary mode of transmission for COVID. And it's transmitted several different ways. So one of the first ways is droplet, just like flu, that 3 to 6 foot rule. You know, you cough, you sneeze, those droplet particles go to 3 to 6 feet and can infect another person's mouth, nose, mucous membranes. There's also short-range aerosol or short-range airborne transmission. And again, this has been an area of talk and somewhat controversy of, is COVID truly airborne? But what we do know is that a person can contract the virus when infectious particles that pass through their air are inhaled at a short range. And so this is definitely an issue in the hospital, especially when we have patients that have aerosol generating procedures. There's also large range aerosol or large range airborne transmission, depending on the surroundings that you're in. And we have learned that this virus can also spread in poorly ventilated or crowded indoor settings where people tend to spend longer periods of time. And this is because aerosols can remain suspended in the air or travel farther than the traditional conversational droplet distance. And then we also have the indirect mode, again, just like with flu, that if you touch an object that has been contaminated with the COVID virus and then touch your eyes, nose, or mouth. Next slide. So COVID is constantly changing and accumulating mutations within its genetic code over time. And new variants are expected to continue to emerge. Some variants will emerge and disappear, while others will emerge and continue to spread and may replace previous variants. This infographic is a picture of all of the mutations and variants that have happened in just 3.5 short years. And you can see all the way to the left, the original strain, you know, the alpha strain, and then we had the beta strains. And then as you go to the right, you can just see all of these mutations and variants that have changed over time. And this also what makes getting a vaccine so difficult when we have a virus like COVID that is constantly changing and mutating. Next slide. So the COVID overview, onset of symptoms is much longer. It's 2 to 14 days, ranging from very mild symptoms to severe disease. Your period of contagiousness is up to 10 days after symptom onset for those immunocompetent individuals. For those that have a critical case, those really severe cases that are admitted to the ICU or individuals that are immunocompromised, the contagiousness can be up to sometimes longer than 20 days. In healthcare facilities, we use transmission-based isolation. We do contact precautions with an N95 and eye protection. And for those individuals that have aerosol generating procedures, we would put them in airborne isolation also. Complications of COVID are broad, from very mild to life-threatening. And like I said, and gave you the example with flu, this virus can trigger your immune system to go into overdrive, which can kill tissue and damage organs. And with COVID, we see acute injury and we also see chronic injury. So in the acute disease phase, we very often see individuals hospitalized with lung, liver, cardiac, kidney, and coagulation issues. Chronically, many of you have heard of long COVID, where individuals, after they recover from their acute phase, continue with fatigue, lung, heart symptoms, neurological and digestive symptoms, joint issues, and for females, changes in their menstrual cycles. Next slide. This is just a snippet of disease burden, showing the millions of confirmed cases and deaths that have happened with COVID. I will say the confirmed cases, I would take that data with a grain of salt, and that the numbers are probably much, much higher than that. These statistics are related to molecular testing and PCR testing. And we know, since that we now have home tests are not reported in these numbers, nor are clinics or doctors' offices that do point of care testing. So the actual confirmed cases circulating is much, much higher than what's being reported at a national or local levels. Next slide. COVID forecasting is very difficult. They try to use mathematical modeling, but with the changing of variants and mutations, it makes it very difficult. Many of you may remember early on in COVID, we had very good mathematical forecasting. We would have weekly meetings regionally where I live, and where the projections were and where we ended up were very, very similar. But that is no longer the case. And they still do have mathematical models looking at it, but it usually can only forecast for up to the next few weeks, which make projections much more difficult. Next slide. So we're going to jump to the respiratory syncytial virus, otherwise known as RSV. RSV is a common respiratory virus that usually causes mild cold-like symptoms. Most people recover in a week or two, but RSV can especially be serious for infants and older adults who are more likely to develop severe disease and need hospitalization. Transmission is in two modes. It can be transmitted via droplets from individuals that cough or sneeze, and it also can be with direct contact, like kissing the face of a child or touching a surface like a doorknob that has virus on it. The onset of symptoms is usually 4 to 6 days after affected. And the period of contagiousness is usually a day or two before symptoms, and on average up to 8 days, although those individuals that are immunocompromised can continue to spread for up to 4 weeks. In healthcare facilities, we usually leave people on isolation until they're clinically improving and a good 24 hours afebrile before we remove them from isolation. Next slide. Disease burden. Each year in the United States, there's on an average of 2 million outpatient visits among children less than 5 years old. There's up to 80,000 hospitalizations regarding children under 5. For adults over 65, it's up to 160,000 hospitalizations. For 65 and older, our elderly population can cause up to 10,000 deaths and up to 300 deaths in children younger than 5 years. And last year was a really impactful RSV year. Like I said, many of these viruses weren't circulating for a couple years during those times of COVID with those strict public health measures. And last year, the 22-23 season had the highest weekly rate of RSV associated hospitalizations than we'd had in the previous 5 years. Next slide. So RSV forecasting is done in the United States. It's done by a national respiratory surveillance system, and they analyze data at the national, regional, and state levels, and these are periodically published. Your typical RSV seasons, as they begin the onset from mid-September to mid-November, they usually peak December to February, and then they start to go away and decline mid-April to May. However, as I had previously mentioned, prior to 2020, these seasonal patterns were very consistent. But, since COVID, the circulation of these viral respiratory viruses has been disrupted. And last year, we peaked at a totally different time than we normally would in July. And the forecasting right now is, they say it's too soon to predict when the previous seasonal patterns will return, if they do return. Next slide. So when we're dealing with infection control measures, and Mary's going to go into this in a little bit more detail, but these are the basics. Stay up to date with current vaccination recommendations. And, this has been an area where we have seen a decrease in vaccination across the board since COVID. It's become very controversial, and there is quite the anti-vax movement nationally. And I just want everybody, I think some of the mindset is as well, it's not going to prevent me from getting it. But think of all of those consequences and morbidity and mortality and those autoimmune responses that you can get from these viruses. And so the best way to protect ourselves is still with vaccination. We want to rapidly identify any suspect cases. So screening at triage areas and healthcare facilities, rapid implementation of source control. We want to encourage healthcare workers, visitors, and that not to come to our healthcare institutions when they are sick. Implement source control. We want to perform viral testing early on, very low threshold for testing people with symptoms. Implement universal use of personal protective equipment, so standard and transmission-based precautions, especially when performing aerosol generating procedures. And then we want to optimize the use of our engineering controls and our indoor air quality. Next slide. The impact to healthcare facilities is huge. I touched base on morbidity and mortality, but nosocomial spread. When you have nosocomial spread in your healthcare facility or long-term care, it's patient harm. Patients are harmed. That has so many consequences within itself. It can cause patient relation issues. Nobody wants their loved one to come into the hospital to, have their hip surgery and then getting COVID or flu or RSV while they're here. There's a huge financial impact to healthcare facilities, capacity issues and throughput. When we have, an influx of these cases, we are already so full in the hospital settings that it really causes capacity issues. And then when we have these hospital onset cases, it really increases these people's lengths of stay. Somebody was ready to go home, then all of a sudden they catch it and they're here longer, and it often leads to difficult discharge planning. And many of these patients, especially if elderly, need a higher level of care, which makes discharge difficult. And then we have the healthcare worker burnout, which are all issues that many of us are experiencing today. Next slide. And I am going to pass the baton off to Mary.
All right, so as Michelle alluded to, respiratory viruses have a huge impact, but each institution has different responses and different scenarios with it. But we can all agree that prevention is ideal, and we would prefer not to have to deal with an outbreak. These are just some pictures reflecting kind of what we deal with in different circumstances. Now, in long-term care, we have all of these. We have community dining, we have activities and games, trying to socialize people. Our common denominator with the hospitals are that we have patient rooms, and all provide mechanisms in different types of outbreaks. Next slide, please. So when you're thinking of the risk, you certainly need a risk assessment, but just think about it more as what worries you. The risk assessment's more formal, but think about the things that worry you at night, keep you awake. If you look at your patient population, are they very young? Are they very old? Are they frail? Are they healthy? Do they move about on their own? Do they stay where you put them? Do they follow directions? Are they cognitively intact? Community risk I look at it a little differently. We certainly look at our neighborhoods, our cities, our schools, where we live. But when you get into the institution, you kind of have to look at the patient unit, the type of patient, how they travel throughout the unit. Are they using the same elevators as another unit where there's an outbreak going on? Take it right down to the nurse assignment or the CNA assignment where people are cohorted, because your risk may lay there. Staff, patient, and visitor behaviors. It would be great if when we put out recommendations or guidance, everybody followed it to a T, but we know that doesn't happen. So we have to really think about those patients and those visitors, what their risks are, what their behaviors are. Can we use precautions effectively? Are they going to follow directions? What happens when you're not there? Do those residents even have the capability of following the directions when no one's looking? Positivity rates, as Michelle said, the data isn't as good, especially for sorry, my phone was ringing, for knowing what the COVID risks and stuff are, but certainly keep an eye out and listen to what's going on. Community activities. I remember with our first COVID outbreak, it was a birthday party around Halloween for staff went to, and they brought it back in the facility, and then we had an outbreak. But think about the activities going on in the building. Are there parties? Are there community lunches? Are there things going on just where people are managing a little bit closer? And really, what's going on? Keep your ear to the ground as far as sick calls, sick kids, people working that just aren't quite themselves. As we mentioned before, like COVID doesn't always present as somebody being super sick. Just keep your ear to the ground and see what's going on. Next slide, please. So this just depicts a bunch of the different prevention strategies. One of them doesn't do it. You kind of have to address them all in looking at what your hand hygiene percentages are. Is there sanitizer out and available? Do people cover their cough? Are they coughing and sneezing on each other? Are they touching each other? Have we educated the staff on how to protect themselves and the residents and families? Have we provided as many vaccines and tried to keep people up to date as possible? All of those contribute, as well as putting in transmission-based precautions when necessary. Next slide, please. So if you are so lucky as to have an outbreak, you kind of look at what control measures you can put in place. Cohorting is a big one, and that goes back to looking at what your risk is. If they have the same exposure, they have the same issue until you prove that they don't, which you do through testing and monitoring and following these people. And your root cause analysis, it isn't always what you see at first that's the cause of it. You kind of have to look a little deeper. Is it staff bringing it in? Is it staff moving throughout the building? Kind of take a deeper look and see whatever's going on, see if you can find a way to fix it or prevent it from happening. And then targeted measures, which we'll take a deeper look at. Next slide. So those targeted measures, your transmission-based precautions, as Michelle reviewed, there's a little bit different for every disease, every virus floating around. What you want to do is use the right precautions at the right time for the right amount of time. It would be easy to say that we could just put everybody on full precautions for everything, but you have to be cognizant of using just what you need when you need it to try and mitigate the healthcare burnout. Personnel management. You got to look at a whole bunch of factors. So we'll look at that further in depth in the next slide, and then environmental controls. So we can move forward. Okay, with those healthcare workers, PPE fatigue, it's a real issue. There's not a lot of good written documentation on it, but it's very similar to alarm fatigue in the ICUs. If we do it all the time, it doesn't seem as important. We also have to look at turnover. I need to prevent that as much as possible. Low levels of health literacy. And this is really important when you look at the different healthcare settings as well as, different community settings. We come from an area of being educated in viruses and in infection prevention, but the average person on the street doesn't have that education. I often teach my students, like in the hospital, you're dealing with mostly RNs and educated staff with some assistive staff. When you get to long-term care and assisted living, you're dealing with people who are here because they care, that may have 6 to 8 weeks of education to be able to do their job. They certainly don't have the same type of health literacy, and we need to help mitigate that by addressing those knowledge gaps with education. And then staffing challenges have affected all of us in every environment. And certainly for long-term care, it happened in all arenas, but long-term care often dealt with guidance from CDC, guidance from our acute care partners that conflicted with what our regulations were in long-term care. For example, putting people in isolation would be the right thing from a transmission-based precaution. However, when you're looking at dementia and behavioral health, forcing someone to do something or keeping them isolated without social interaction is not what we're judged on at a state level. Next slide, please. So some strategies for that personnel management. Encourage staff to stay home when they're ill. And this is kind of a two-folded issue. We all have seen staff that call off frequently and you're not sure they're really sick, and then you see staff that come in when they're really ill. You need to use your partners that are managers within your buildings, managers in your departments, just to kind of know what's going on and assist with making sure people go home and that you're aware of issues. And watch those real-time trends, more sick calls, more people not feeling well. Just, it can be very subtle things, especially with COVID and RSV, it can be very subtle. Collaborate with the schedulers and the OC Health in your facility. Oftentimes we'll start seeing people not feeling well or being out with different things, or having called and talked to somebody. Just being aware of those kind of helps you find the things before they become a full-blown problem. Early outbreak or early control measures can often control or contain an outbreak. More recent example, I just had a few cases of COVID in one unit, and by acting quickly and early, we were able to contain it to 4 residents on one CNA assignment in one area of this one unit, which was great. But the reason I was able to do that is knowing, like, people were just acting different, or somebody that never called off, just to prompt different reasons to look at it. Next slide. So cohorting. Often we think of cohorting at the room level. Can this person be in the semi-private room with this other person? Do they have the same bug? But we need to take it just a little bit broader and look at the unit level and the community level. Oftentimes, looking at one unit and not letting them interact or mix with another unit because something is brewing helps prevent those outbreaks. Restricting movement is another strategy for an environmental control. Having staff wandering from units where there's an outbreak going on to clean units, or floating between dirty units and clean units, increases your risk of spreading the outbreak. Then cleaning. We always want our standard cleaning to happen, and we'd like to have it enhanced when there's something going on, but that's not always possible. We do the best we can. and air and ventilation. Our whole goal with environmental controls is to make the environment as safe as possible for the residents. Next slide. So in this slide, the picture on the bottom left, you'll see all the little X's. Those are residual VRE in a room after it was cleaned. And the picture to the right shows you the different bugs and how long they survive in the environment. As you can see, there's multiple reservoirs, and this is the same no matter what kind of room or clinic or wherever you're at. We try our best to clean, but as Carling et al. Reported, so only 32% of the cleaning is very thorough. So that leaves a lot of places for stuff to be hiding in our environment. Next slide. So this slide shows a comparison of environmental cultures versus clinical cultures in the same area. And you can see with the dirty environment, you end up with patients with the same sort of microbial burden. Next slide, please. So air. Organisms don't grow in the air, but it's a great mechanism for moving it around or just getting it from person to person. As you can see in the bottom right, there's the circle where it moves and how the air pathogens move. It's just a transport medium, but it helps the viruses get from person to person. As you can see that with C. diff, the flushing of the toilet creates a plume, and that bacteria can be recovered in the air at heights around the toilet, can be for like 90 minutes. That's a long time for stuff to be floating around. So despite doing the best we can, the environment creates an avenue for transmission of pathogens. Next slide, please. So instead of just doing a hope and a prayer and hoping that staff do what you've recommended and that your precautions are going to be enough to work, you may want to think about something that works all the time and doesn't rely on the person showing up to work and or being extremely competent. We want everyone to be competent, but that doesn't always happen, and sick calls happen. So DHP provides threat mitigation 24/7, 365 for airborne, surface, transfer, pest, insecticides, and odors. And you might want to consider taking the leap. This is what my facility did because we were looking at trying to find ways to protect our patients despite their characteristics. Next slide, please. So DHP, it's a gas. It diffuses through the air. It has very safe levels for anyone in that environment. Synexis, the DHP, puts out 2 parts per billion, which is 1/500th of the exposure limit as regulated by OSHA. And it's very effective at reducing the microbial burden. And it doesn't accumulate. Excuse me, next slide, please. The animation, please. So on the left, you'll see kind of the reduction as you do standard cleaning or even enhanced cleaning. It gets much better when you clean, but then as soon as you let people back into the room or people start touching stuff, your environment starts getting contaminated again. When you couple that cleaning with DHP, you can see a sustained reduction despite the ebb and flow of surface contamination. Next slide, please. So this is just a slide looking at the effectiveness of DHP on the influenza virus in a controlled environment. As you can see, it pretty much mitigates the influenza in the environment. So you want to know how that works in real life. So let's take a look forward. Next slide. So I'm going to share our success story here at this nursing home. And for those of you who aren't familiar with long-term care, I'm going to give you a little primer on it. So in long-term care, you want to say, we're going to terminally clean rooms and do stuff when the patients are out of the room. We might have to wait 10 years for that to happen because we don't really have a lot of turnover of beds. People live here. That's their home. They're here for days, weeks, months, a lot of them for years. There's a lot of communal activities. People are encouraged to come out of their rooms, to eat in the dining room with others, and participate in activities. Some of these communal activities are for their mental well-being. Some of it is simply so that we can provide care. People are here for a reason. A lot of them have aspiration risk or need help being fed. To accomplish that and get everybody fed, we need them all in the same room to be able to do that. A nurse can watch many people eating and be there to respond in an emergency. We can't do that if they're all in their own room. We have a big therapy gym where everybody in the building comes to do therapy. It's a big common area. And as I said, these people are here for a reason. Most of them require a significant assistance with ADLs, which is frequent throughout the day. And then to top it off, staffing. So if a facility has 300 staff on the payroll, some departments may staff with a couple or up to 5 people. So one call off could equal 20% of the entire staff for the day. It's really hard for an EVS staff to do enhanced cleaning if they're down by 20% of their entire department for that shift. Next slide. Pull in the animation. So this is a picture of our neurobehavior unit. We did a study when we implemented our DHP. So as you can see on this unit slide, it's a T. Everybody ends up crossing in the middle. A lot of time is spent inside that red circle for passing through, sitting in the milieu watching TV, moving to the dining room on the left. This is like unavoidable interaction. Next slide. So if you're not familiar with these neurobehavioral residents, these are dementia with unpredictable behaviors. So they're unable to follow commands. They're confused. When you try to redirect them, they get very agitated at times. They may punch people. They may interact with other residents inappropriately. They can be very aggressive. They don't understand personal space. Some of them become aggressive. Some of them become more affectionate and have a huge need for personal touch. And they're always in motion. So with this type of resident, even putting in transmission-based precautions doesn't help. If you dress to go in a room, but everybody's touching you, it doesn't really matter. Next slide. So we installed DHP. It went live on December 1st of 2022. We did a study around that time. We did environmental samples 3 days before, and then 14, 28, and 55 days late after the installation. And as you can see, there was a huge decrease in microbial burden that was sustained. Next slide. This slide shows air particles in the VOC. And again, with this slide, there's a huge decrease. Nothing else changed on this unit. Next slide. So I'm going to give you a little comparison because my building decided to give us a nice controlled study. So in December 2020, right before the vaccines came out, we had an outbreak on this particular unit where every resident was sick, 40% died. Everybody was required acute medical interventions, and it was like a train hit this unit. Next, please. So when we went live with DHP, this is my ideal outbreak forever. There was a 40% attack rate, no death. 2 of these cases were hospital readmissions that brought it back with them, and they were very mild symptoms. So we started our testing and we found 2 more cases and then 2 more cases. In the span of like 3 to 4 days, we had identified all the cases and we just wrote out the incubation period. Nobody was really sick. It was very, very slow, no big deal. Next slide. So bringing that data forward, our long-term care unit decided to participate in the fund. Next column. So this long-term care unit is a 40-bed unit where most of these residents can follow some directions, but they do have a lot of community interaction. They spend a lot of time in the dining room together, spend a lot of time watching TV together. This unit had no DHP. It was a 33% attack rate, but it lasted forever. It was over 3 weeks before we stopped finding new cases because they kept exposing each other. This involved testing every couple days for anybody who was exposed, which is about half the unit. And providers were seeing all these people that were exposed and becoming COVID positive. So this was kind of a nightmare and a lot of work. Next slide. So again, we'll bring forward the neurobehavior unit. Next column. So then again, we had an outbreak in our skilled rehab unit. So the difference in the skilled rehab unit, these people are able to follow directions. They're on their way home. They're cognitively intact, trying to get home. This unit didn't have DHP either. It was a 70% attack rate, very rapid outbreak. Basically, within the span of a day and a half, the entire unit was down with COVID. In this unit, everybody was doing all the transmission-based precautions and doing them well. Despite that, we had this huge outbreak. It was very challenging. Next slide. So our conclusions from our study here, the DHP provided supplemental continuous passive reduction in that burden. We didn't really study, the infections can't totally be related to DHP, but if I have to choose an outbreak again, I would choose for it to be on my unit with DHP. I don't worry about them anymore, despite on paper, they are my highest risk population. And next slide. We're gonna turn this back to Michelle for one of her success stories.
Thanks, Mary. Next slide. So I'm going to just give you a brief overview of DHP. We have installed it in our operating room and added it to our environmental bundle. In 2018, we had a significant increase in orthopedic surgical site infections. And at the same time, there was ongoing construction and there were vast environmental concerns, more so with the surgeons, and then also with infection prevention. And it was actually our orthopedic surgeons that came to the table and demanded, in a sense, some type of environmental control to help with bacteria mitigation that we were seeing. At the time, we initiated a robust SSI reduction initiative, which was both clinical and environmental. And one of the things I want to say about these environmental augments like DHP is when you add these on, they're all about a bundle approach. Most of everything that we do in healthcare is a bundle approach, whether you're talking about CLABSI reduction, CAUTI reduction, SSI reduction, reducing C. diff in the environment. All of these different initiatives, there's not just one smoking gun. And usually we have to put many things in place as a part of a robust bundle to see improvement. And that's exactly what we did with adding in DHP, along with many other clinical things that we put into place. DHP was installed in our orthopedic operating rooms and also the restricted airway surrounding the rooms and hallways. As a result of our bundle initiative, 1 year after installation, we had a 60% reduction in our surgical site in infection cases. And, you know, now we are on going on 5.5 years later, and we have continued to sustain that with an 80% reduction. And kind of like Mary said, we can't say clinically correlated exactly, but adding on the DHP along with other mitigation strategies, we had a significant improvement in our outcomes. Next slide. So in summary, your contamination threat never stops. So why would you want your disinfection technology to stop? And unlike other agents out there, other environmental UV, UVC, or even some ozone producing technologies that only provide short-lived or localized disinfection, DHP exists safely and effectively within the environment, and it continually reaches difficult surfaces, contaminants, and airborne microbes. And again, when talking about these other environmental things like UV and UVC, they are very important also. And many times we will add DHP onto those other things that we have in our environmental bundle. But the fact that this is continuous 24/7 and adding the air quality and the air disinfection, it really heightens our environmental bundles to the next level.